So we have a special treat this morning. We always have excellent speakers. This morning we have more excellent speakers for you, and it's my pleasure to introduce our first speaker. Dayna Bowen Matthew is a professor of law at the University of Colorado, School of Law, and the School of Public Health. She has served as a senior advisor to the director of the EPA's Office of Civil Rights and has been a Robert Wood Johnson Health Policy Fellow. She's currently a visiting scholar at the Brookings Institute and the Congressional Black Caucus Foundation. Ms. Matthews has extensive experience and expertise in our space of healthcare disparities. She's the director of the Colorado Law School's Health, Law, and Policy program, and she formed an interdisciplinary course which she taught on poverty, health, and law. She co-founded the Colorado Health Equity Project and recently published a fabulous book, Just Medicine, A Cure for Racial Inequity in American Healthcare. Dayna will speak to us today on the race problem in American health, the work that remains. So please join me in a warm Movement is Life welcome to Dayna.
Good morning. So this is the right group for me. I can move around. I don't have to stand here. Awesome. This is... All right, she just told me don't fall. So this is the group this is the first group I get to brag, and I want to tell you, I arranged this. But on Sunday, I finished the New York Marathon, and thank you. If you go to the website, you will see I was moving, but I wasn't moving to break any speed records, right? But I was moving for life, and I want to share that with you because it's relevant to what I'm talking about throughout the course of the morning. This, however, is an advanced group. I'm going to tell you, I stood back there and I thought, I can go a little deeper with you. So if you don't mind, I am going to use my slides, but I'm going to go a little bit deeper than what I would usually do from these slides. Because even looking at the Vicious Cycle film, I'm thinking this is a group that's not only informed and active in the space, but you're ready for me to push you just a little bit further, if I may. And so I'm going to try and do that. I'm going to push you just a little bit further. So thank you first to Frederick Douglass. That's the source of my title, The Race Problem. If you ever want to read one of his phenomenal speeches, it's a speech that he gave at an AME church right here in Washington, D.C. in 1890. And that speech did a little bit of what I want to do here, and I want to say, you know, what we call the race problem in healthcare is really not a race problem. I want to challenge us. But I do want us to focus on race qua race, all right? So that's my first real challenge to you, because even though this is a very advanced, very knowledgeable group, there is a temptation to not want to talk about race because it's so touchy. A temptation to not want to talk about racism because it is so personal, and a temptation to become defensive. So just very briefly, I have the infant mortality numbers up here. We could do this all day, but I want to be clear. Infant mortality among the Black community is twice as high as it is among the white community, almost the same for the Latino community, right? Usually when we see health disparities, we can change that dynamic by controlling for socioeconomic status, for income, and for education. Not so with infant mortality, not so with so many other, but this is the very clear, so many other illnesses. This is the very clear example that when we control for income, we are still looking at a disparity whereby Black mothers who are affluent will have twice the infant mortality rate of white mothers who are below the poverty line. Similarly, with education, we cannot remove the disparity for infant mortality by educating the moms. Moms who have a college education and are Black still experience approximately twice the infant mortality of moms who do not have a high school education and are white. So it is very important to me that we talk about this problem as race specific, as ethnicity specific. We know that there are some parts of the problem that we can solve by addressing things for socioeconomic reasons or changing structures of education. That's not the type of problem that I'm talking about today. So I'm going to start with a personal story. I had the Lyft logo here because during the time that I was training for the marathon, I used to get up on Saturday mornings. This is why I'm never running another marathon again. Get up for Saturday mornings at 5 a.m. and you'd spend basically your whole day running these really long runs and doing these routes and doing these exercises, and so I had to take a Lyft drive. I live on Capitol Hill right now. It's about 8 minutes from my start point where my group met. 8 minutes, right? So I call the Lyft driver, and you know, you've used the app, you have to put in your destination, and it just so happens that my picture doesn't come up clearly, because my husband and I took the picture together, so it's just like two half heads and eyes, so you can't really see who I am. But you could see where I was going. So this happened about 2 months ago. I call the Lyft driver. He arrives at my house. Because I had to go get some fuel, I come behind his car. I'd gone to the grocery store to get some fuel. That's what runners call a banana, right? And so I gone and got my banana. I jumped in his car. He turns around and looks at me and he goes, "Oh, you're going to Virginia?" And I said, "Yeah, I'm going to Virginia and I got to be there in about 8 minutes." He said, "I've been driving all night. I'm not taking you." See? So I'm a woman of a certain age and I'm thinking, what is wrong here? I said, "Oh, yes, you are taking me. And I got to be there right now. I want you to, you took this call, you're taking me." He turns around and cancels the ride with me in the car and says, "Get out of my car." I'm not making this up. So remember, I'm angry. He then locks the door and starts to drive away. Exactly. I'm in the car. Now I'm not only angry, but I am petrified. And I then said, I slammed the door and I said, "I want you to let me out of this car right away." All right, so you see I'm increasingly irrational. First, "You will take me." Then I'm slamming the door. "I want you to let me out of this car," right? He stops the car and he turns around and looks at me. I promise you I am not making this up. He looks at me and he goes, "Do you want to go home with me?" And I said, "I want to get out of this car." He let me out, and then I did the third thing. So I went from angry to petrified, and I did the third thing that was totally irrational. By now, I want you to hear from me that I was coming unglued. I walked around his car, and I opened each of his 4 doors. What is that gonna do? Not a thing. I'm just acting crazy at this point, right? I'm angry, I'm scared, and I'm crazy, right? Here's the point of the story that I really want you to catch. About 2 days later, because that happened on a Saturday. Sunday I wasn't right, Monday I wasn't right, but 2 days later, I am in a cab with a Lyft driver, and I say, I gotta tell somebody this story, because I'm anxious, I'm grumpy, I'm short with people I love, I need to tell somebody what happened. So the cab driver, who was another Lyft driver, told me, "Go ahead and call Lyft's emergency line." I call Lyft's emergency line. The person who answers the phone has a Southern accent, another trigger for me, right? Has a Southern accent and says, "What's your emergency?" I says, "My emergency is that I think I was discriminated against racially. I think I was discriminated against racially." Now, the person on the other line, if I ever met them, I would marry them to my first child, because that person said to me, "That is an emergency. Wow. Nobody should have to have that happen to them. I will stay on the phone with you all day if you want to talk about this. Tell me what happened." Exactly. I was on K Street when this happened. I was dressed for success going to an 8 o'clock meeting. I broke down and wept. No lie, I simply started weeping. And the reason, now I'm off slides, this is an advanced group. The reason I'm off slides, seriously, the reason I'm doing this is because I want you to know, in addition to my slides, which are going to talk about implicit bias, see, I'm trying to get back on point, right? Implicit bias and understanding it, distinguishing it from explicit bias and racism. In addition to the fact that I want to examine the impact of implicit bias, this is my agenda for today. And in addition to, thirdly, I would like to look at a toolkit for each of us to use once we understand the impact of implicit bias, I want to add something to this agenda. I want you to understand that what happened to me happens to your patients, right? And they embody what they experience with respect to discrimination, implicit bias, in their physical bodies, right? So the allostatic load that I carry, is that a term that's familiar to everyone? The allostatic load that I carry includes that experience, right? So when I, assume I'm your patient, I enter into your examination room, I'm carrying that experience physically, I'm carrying it emotionally, I'm carrying it intellectually. So when you say to me, you need to exercise more, you need to move more, I am going to have that hurdle to get over also. Just understand that. I'm adding that because this is the AP course, right? But there's plenty of data on that. All right, so implicit bias is something you guys know. We can skip over most of this slide. I just want to make the observation that it's environmentally generated. It is really important to understand how it operates so that we can distinguish it from explicit bias and racism. It is not the same as me intentionally being a bigot. It is not the same as me consciously choosing to discriminate. That is a really important distinction. What happens with implicit bias is that my environment, the experience I just told you about Lyft, the radio stations I listen to, the movies I go to, the television that I listen to, the conversations that I have at the dinner table that I overhear in the train station, in the marketplace, and so forth, all contribute to my store of social knowledge. That social knowledge is unconsciously accumulated. And listen carefully. It is not only unconsciously accumulated, but it often, in fact, most often contradicts your explicit preferences. So your explicit desire is to be an egalitarian. In fact, in this crowd, your explicit desire is not only to be equality-minded, egalitarian, and caring, but you are scientists. You make decisions objectively based on data. Not only that, you are people who have already heightened your awareness. Let me assure you that does not change the fact that your implicit biases, which have been gathered environmentally, are most likely the same as most Americans, minority and majority. Anti-Latino, anti-Black, because you live in this place, right? It doesn't have anything to do with whether you're a good person or a bad person. So these social stores of knowledge are triggered, I pull them up, and I react in ways that are contradictory to my explicit preferences. You've seen the implicit association test. I'm going to run through these. This is a group that understands we can measure implicit biases. When we measure implicit biases, what we find is that over 70% of Americans have an anti-Black, anti-white bias. Over 70% of Americans have an anti-Latino, pro-white bias. Now, there's something unfortunate about that language because right away it sounds so much like racism, right? It sounds so much like what we object to. In fact, we have very good data that most people are not overtly racist. And I'm going to go on record right here, and I know this is controversial, but I'm going to go on record right here and say that although racism clearly exists in the healthcare industry, don't get twisted. You're not hearing me say that there's no such thing as explicit bias or explicit racism. I am going to go on record and say that I do not believe that most disparities are the result of explicit bias or racism. I think what we're doing today is picking the fruit that is no longer hanging. The low-hanging fruit about segregation, that was picked, right? We're not talking about disparities that arise out of this dynamic, out of unconscious bias, and you guys already recognize that. So the takeaway message first that I would like you to take away is that unconscious racial bias, it is the new virulent form of racism. It is not the same as racism, old days, old versions of prejudice and bigotry. It is different, but it is as pernicious. It is as harmful it is as dangerous and perhaps more so in healthcare. So I want to go through some of the research. Again, I'm going to spend more time on the actual research than I would normally because I think it's really important that the concepts I've just talked about are also underscored by what implicit bias does to African American health. This is true for Latino health, for minority health. Unfortunately, the state of the research right now is almost always focused on African Americans as patients. And I say that unfortunately, not because it is unfortunate that we have that data, it's unfortunate that we don't have more data, right? And I'm saying that in this room because it's possible that this is a room that will generate more data, right? So I'm going to talk about 3 studies. The first is an Alexander Green study. How many people already know about this study? Not quite half, so enough for me to spend a little bit of time. Implicit bias has 3 to 6 really important impacts on health disparities. I'm going to do 3 of them now. If you're interested, I can talk about the other 3 later. But Alexander Green is an important contribution to the first impact, that is implicit bias's impact on treatment decisions. That's treatment and diagnostic decisions. So in this study, Dr. Green and his group recorded vignettes of a patient who was presenting with identical, or patients plural, identical histories and physical, identical data, and identical complaints of coronary artery disease. After the vignettes, the physicians were then given a questionnaire about their treatment. The reason the coronary artery disease example is so useful is because there is a treatment of choice. In this experiment, it was clearly going to be thrombolysis based on what was presented by each patient. The physicians had, before they saw the vignette, done 2 things. They'd taken that implicit association test, so they had a score of their implicit pro-white, anti-white, pro-black, anti-black biases, and they had also taken a questionnaire about their explicit biases, right? So their explicit racism. Do you prefer intentionally one group over the other? The data was then correlated between their biases, explicit and implicit, and their recommendations for treatment, right? So the hypothesis, or rather the research question was, what is the relationship between implicit bias on the part of the physician and their treatment decisions, right? So understand that in contrast to what the implicit association results showed, high implicit biases, or at least those that mimicked and mirrored what most of Americans have, most physicians in this study had very low explicit biases, very low prejudice, very low explicit bigotry, right? And that's the combination that we see most often. Here are the results. The most important thing that you should see is that the lines don't go the same way, right? That is, we are correlating the implicit association score on the x-axis with the likelihood of recommending treatment of choice thrombolysis, in this case, on the y-axis. And what you see, the most important of these 4 graphs is the one in the far lower right corner, which is the composite of all implicit association tests. The inverse relationship for Black patients between a high implicit association score and a low likelihood of recommending the treatment of choice. And it is reversed for whites. Here's the other thing that's important, very important, especially for this group. There were, of the group of some 300 participants in this study, 60 who were told expressly what the study was about. This is a study about treatment and race. So they knew, unlike the others in the group, that they were being examined on their treatment decisions related to race. This is the result for that group. They were able to control their implicit biases. Simply knowing that one has implicit biases is enough to begin to change the harm that those biases cause. I want that to sink in. That's really important. what work you are doing this conference in order to understand unconscious bias, in order to defend against it, to ask the questions of what you can do about it, that is enough to move the needle. You are to be commended. I want to move on to the second study. There's a second group of studies by Michelle Van Ryan. She's at University of Minnesota. And she looks at a research question concerning the relationship between implicit bias, I'll use that term, unconscious bias. I sometimes use unconscious racism, depending on what group I'm with, right? Interchangeably, same thing, right? When I really want to upset the apple cart, unconscious racism, right? She asked the question about the relationship between implicit bias and perceptions, that is, the perceptions of the provider before the provider walks into the room. How does the provider perceive the patient? Her studies are drawn from videotapes, interviews, and pre-post studies and conversations with providers. This I'll go through quickly because it's not very complicated to go through. What she has shown is that a majority of physicians, they can be Black, white, Latino, Asian, Native American. Please let that sink in. That's not something I emphasize with every group, but this group needs to understand that it is really important that because implicit biases are environmentally generated, we all have them, right? I've taken the implicit association test. If you twist my arm and buy me a drink, I'll tell you where I score, right? But most physicians have these perceptions that minorities over-report their discomfort, that minorities do not comply with medical advice for different reasons. She breaks down the reasons. They don't have the resources. They don't have the intelligence. That's one, right? They don't have the intelligence or understanding. That they abuse drugs or alcohol at a greater level or frequency than whites. That's just empirically untrue, right? But the perception going into the encounter. So arguably these perceptions, you can read the rest of the list, these perceptions have an impact on the treatment decisions and on the interaction and the nature of the interaction that patients and physicians have in the clinical encounter. Here are some more. Blacks are less cooperative, generally less well-educated. One that I haven't put up that's really important to you, how many of you have heard of the University of Virginia pain study of physicians in training and their perceptions about pain, right? Blacks have thicker skin, empirically untrue. Blacks have a different way of coagulating. Our blood coagulates differently. These are perceptions and they affect the treatment encounter. The third set of studies is by Lisa Cooper. Lisa Cooper is a physician that is at the Johns Hopkins School of Medicine. She records by videotape encounters between physicians and patients, and then she codes them for the differences in communication. The take-home message here is not only that the physicians that are more biased when she coordinates those coded interactions with implicit bias or implicit association test scores, the physician's length of encounter, the amount of time that they talk to a patient of color differs based on race. The level of eye contact, verbal dominance, how much information does that physician take from the patient is different Black versus white patients. The content of the information and where they sit, right? Now here's some problems with this study. Number one, all of these studies talk only about physicians, right? We don't have very much information about nurses, and we need it. We don't have very much information about other clinicians, physician's assistants, physical therapists, right? And I contend that we don't have enough information about people who sit in the front office. How many of you gone to the dentist, got a nasty attitude, and just decided, I'm not going back there? Not because of the dentist, but because of the person in the front office. So those biases probably have information. Now, this is a group, again, advanced AP studies. I'm going to go there with you and let you know that patients have implicit biases also, right? And this is why it's so important for us to talk about this in honesty, but without judgment. right? Because let's say I'm your patient, I'm coming to you with some implicit biases. I just told you about my lived experience. So if you, my provider, sit back, fold your arms, don't make eye contact, what am I going to assume? I'm going to assume you're a racist. And then I'm going to give you less information. I'm going to make less eye contact. I am going to speak in a mumbly voice. I am going to potentially not even come back, thereby disrupting my continuity of care, right? And there is a vicious cycle of communication, or I should say miscommunication, that implicit bias can affect. Now again, I'm going to go off slide one more time, and then I promise I'll adhere to it. Am I running out of time? How am I doing? Okay, so I'm going to go off slide just for a second. One of the things that a very sensitive, knowledgeable, and effective provider can do about this communication, and I'm going to get to the toolkit in a minute, is realize how far-ranging the experiences that lead to your patient's biases are. And I'll push you a little bit to ask yourselves, what role does the provider have in some of the social determinants of health that are affected by implicit bias, right? So I said there were about 6 mechanisms. The mechanisms that I talk about, I've done 3 of them here: communication, patient reactions, treatment decisions. There are 6 others. This is from my book, Just Medicine, and if you want to talk about the rest of the 6 mechanisms, we can talk about that. But now I want to turn to the second takeaway message, that is not only that unconscious or implicit bias significantly influences health equality. When I say significantly as standard racism, right? Even though it's different. But I want to go to the fact that it systemically, implicit bias, systemically affects your world and your patient's world. What's your role with respect to that? I have ideas, not answers, but I'm pushing all of us now to think about those systemic influences. This picture, are you familiar with it? This is Governor Snyder of Michigan. Any Michiganders here? So one of the things that I did during my, okay, so we're there, we get it. One of the things that I did during my wonderful Robert Wood Johnson Foundation fellowship was I got the privilege of working with Debbie Stabenow, the senator from Michigan, at the moment that the Flint lead water contamination crisis was declared. I know it's not a good thing, but I was like a kid in a candy shop because I do implicit bias, I do health, and I want to talk about the structural impacts of implicit bias and your role with respect to them because they affect your patients, right? If we had time, I'm not sure we do, I would play for you a little part of the conversation between our new vice president, Mike Pence, and his competitor during the debate when they were talking about implicit bias. The reason I would play it, and let's be clear, again, let's not be twisted. Mike Pence is my vice president now. I respect the office, and whether he got my vote or not, I'm not playing this to downplay him. I'm playing this to talk about implicit bias, right? When you saw the looks on those 2 gentlemen's faces, they were in anxiety talking about implicit bias. They both got it wrong. Okay. I don't know how to do it. How do I make the link, the blue link? Can you make it go?
If it's been embedded.
Yeah, it has been embedded, but what do I click?
No, go get it.
Okay.
It's all over.
So look at their faces. They both get it wrong. So you know more about implicit bias than either of them. So this is not a critique on what they know about. But look at their agony. Look at the anxiety. Look at how they're talking about implicit bias. What they're doing is reacting to the negativity, the judgment, right? The blame and shame history that has gone with implicit bias, that has gone with unconscious bias. And this is what we have to remove because it is so important, because it's so ubiquitous, right? I think in your film about the vicious cycle, someone made the correct statement, I'll paraphrase it, to be human is to be implicitly biased, right? We have to organize our lives around implicit bias, the way we live safely, is by exercising or implementing some. So there can be negative biases and positive biases. I'm definitely in the advanced class now, and I'm vamping until they get to the tape, right? There can be negative biases or positive biases, positive uses and negative uses of both types of biases, right? So we can do a 2x2 grid, and you find out we could use these. So look at them just briefly, about less than 2 minutes, talk about implicit bias.
The bad-mouthing that comes from people that seize upon tragedy in the wake of police action shootings as a reason to use a broad brush to accuse law enforcement of implicit bias or institutional racism. And that really has got to stop. I mean, when an African-American police officer in Charlotte named Brentley Vinson, an all-star football player who went to Liberty University here in the state, came home, followed his dad into law enforcement, joined the force in Charlotte in 2014, was involved in a police action shooting that claimed the life of Keith Lamont Scott. It was a tragedy. I mean, we mourn with those who mourn. We grieve with those who grieve. We're saddened at the loss of life. But Hillary Clinton actually referred to that moment as an example of implicit bias in the police force, where she used, when she was asked in the debate a week ago whether there was implicit bias in law enforcement, her only answer was that there's implicit bias in everyone in the United States. I just think what we ought to do is we ought to stop seizing on these moments of tragedy. We ought to assure the public that we'll have a full and complete and transparent investigation whenever there's a loss of life because of police action. But Senator, please, enough of this seeking every opportunity to demean law enforcement broadly by making the accusation of implicit bias every time tragedy occurs.
Elaine, people shouldn't be afraid to bring up issues of bias in law enforcement. And if you're afraid to have
I'm not afraid to bring that up.
All right, so do you see how anxious they are talking about implicit bias, how it's associated with structural racism? Is implicit bias the same as structural racism? No. Is implicit bias structural, however? Yes, right? Do we have to stop talking about implicit bias in order to correct it? No, if we stop talking about it, it's going to be unaddressed, right? We have to talk about it. But how do we have the conversation? Here's my point by showing you this. We must have the conversation in a way that relieves those two good men from the sense of anxiety and judgment and demonization that associated and accompanied their discussion of implicit bias. We have to be able to talk about the effect of implicit bias because it's far-reaching. Let me talk about the difference between implicit bias and racism. I really want to go there, right? So this is Michigan, Detroit circa 1942. When we talked about racism in housing, this is what we were talking about in 1942. 52, 62, maybe even a little bit still. This is not implicit bias. Implicit bias is when a neighborhood, I'm talking about Flint, is 44% below the poverty line, 55% African American, and the majority of people live in sick houses like this. How does that happen? Redlining. It happens when a discriminatory government unintentionally removes elected officials to save money. It happens when a real estate broker shows me 14% fewer houses, 11% fewer apartments than she shows you when you're white. That's how we end up with this. It is implicit bias. Okay, again, advanced course. Not only is the house sick, but if your patient lives in this neighborhood, is there a walking trail, a tennis court, a safe place for your patient to move in order to be healthy? What is our role in recognizing that implicit biases reach outside of the healthcare system and affect the social determinants of health, such as housing? Another social determinant of health, education. This is what racism used to look like with respect to education. Is that what's going on today? In Flint, Michigan, it turns out that of 15 public schools, 8 of those public schools are 80% or more black. Think about that. It's like Brown versus Board of Education never happened. 15 public schools, 8 of which are 80% or more black. Is that from the old version of racism? No, it is from a structural impact of not only discriminatory school influences, but we could go on about discriminatory disciplinary differences in those public schools in Flint. We're starting from the age of 3, the number and frequency of black male children who are expelled, 3 years old. I have 3 children. And I have wanted to expel them from my family on occasion. But it didn't start at 3 years old, right? It's recently developed. I'm going to move on. Disparities in funding, the number of AP courses, the number of after-school activities, the funding that would address obesity in schools, school-based lunches, nurses, exercising, physical ed programs. They're different by race. This is also an area that is affected by implicit bias. Lastly, food distribution and discrimination when it was racism looked like this, right? Now, the reason we confuse racism with implicit bias is also about race, right? That's one of the reasons. We confuse it because both have pernicious impacts, right? We confuse it because they both have structural influence, right? But are these people acting intentionally or unintentionally? Right? When they're throwing food, they're acting intentionally, right? On the other hand, when you look at a map of Flint, Michigan, this is the map that we used when we were trying to figure out how to get healthy food to the Michiganders who were victims of lead poisoning. One of the problems was there is not a single chain grocery store in the city of Flint, Michigan. No Safeway, no Kroger, no King Super, no Piggly Wiggly. I'm from the South. No Piggly Wiggly, right? Is that because of intentional racism? No, it's because of unintentional decisions. And again, I'm pushing you, right? You understand unconscious bias. We can change implicit bias, but do we have a role to change it beyond the clinical setting to the extent that it affects our patients' social determinants of health? All right, takeaway message number 3, we can change it. Let's talk about the toolkit, right? I'm gonna do this one really fast. I wanna talk about the toolkit on 3 levels. I wanna talk about a toolkit with respect to structural changes that you and I, all of us can make. I wanna talk about it secondly on the level of administrative policy changes that you and I and all of us could make. And then I want to talk about it on a level of 3 personal levels that you and I and all of us could make. Shortest amount of time on the structural level. This is where I live because I'm a lawyer. I live with the Section 1557 of the Affordable Care Act. Even if the Affordable Care Act does not survive the next 4 years, there are analogous regulations that have to do with Title VI. It is my talk to lawyers that most explicit bias or segregation-oriented disparities were dealt with because people like those in this audience brought complaints and lawsuits. I think you could do that when you see structural problems with implicit bias. The law now accommodates that. Section 1557 definitely does. If you want to talk about more about how to do those, there are provisions to make administrative complaints. I urge you to think about doing that. There are provisions to make voluntary and negotiated settlements of those complaints. And then there's, of course, litigation, which is the nuclear option. So that's a structural way that you could address implicit bias. Let's spend more time on the policy changes. There is a book, actually a set of books by Howard Ross called Everyday Bias. If you like the kinds of policy changes that I'm about to describe, they are described in more depth in those books. I think they're very useful for organizations that are serious about making a cultural commitment to remove the harms caused by implicit bias. The first recommendation is that the cultural commitment is announced. It becomes a change of the atmosphere, the norm, from the top to the bottom, from the bottom to the top. In other words, leadership of an organization announces that the problem of implicit bias is no longer one that is demonized, but it is one that is a responsibility of all members of the organization. Probably this is the second most important thing you could do, debiasing training. The difference between cultural competency and debiasing training is this. Debiasing training is a change of habit, not a change of knowledge, right? It's a change of the way that you use information, the way that you access information, and the way that that information informs you. So the fact that we do cultural competency training is a good thing. It's a very important thing, but it aims at explicit biases, not implicit biases, right? So I use the analogy that I used to be a speedy driver, very speedy driver, like 4 tickets in a month speedy driver, right? Yeah, I'm better now. I have been debiased. How did I get debiased from speeding? All right, yeah. I wish I ran as fast as I drove, right? So I've been debiased. How did I get debiased? It took me attending a 1-semester course. Mandatory, I didn't do it voluntarily. Where my habits were changed, the associations were changed. I was given new tools. I was made to understand that the reasons I sped were automatic and were things that I could do, I could accommodate them. This is what implicit bias debiasing training does, and it's very effective. It's very, very good. It also includes counter stereotypes. Your film about the vicious cycle did a wonderful job with respect to counter stereotypes. What does counter stereotypes mean with respect to healthcare and implicit bias in healthcare? It means diversifying the entire workforce in the healthcare setting. Now, again, advanced course, so let me be a little bit more transparent. Remember, there's a tension between the fact that we have evidence that it doesn't matter what color you are, what race you are, how you identify, you probably have implicit biases that are like everybody else's implicit biases. Doesn't that seem in tension with the idea or the recommendation that you need counter stereotypes? People who are diverse in their backgrounds throughout the workforce. It is not at tension with that, right? Because part of the equation is how the patient relates to the provider. Right? And we have very good data, just like the person in the film said. We have very good data that patients who are in race concordant or ethnicity concordant dyads for delivery of healthcare have a higher level of satisfaction, have a higher level of adherence, right? And that doesn't have to be unique. We're not telling you that all relationships have to be of same color, same gender, same ethnicity, but the diversity matters. Similarly, in counter stereotyping, the trainer matters, right? Decision-making teams should be diverse, right? These are very important systems that an organization can make to change. How many of you know about the experiment that had to do with orchestra hiring, where women, right, were not being represented among those hired to play in very high-level symphony orchestras, right? So the structural solution that those interviewing people to play in an orchestra adopted was by putting a curtain between the decision-making committee and the person trying out, and also carpeting this floor so that the person arriving for an audition wouldn't be prejudiced or biased against by the clicking of their heels. So you didn't know whether they were, what gender they were. Right? These are the kinds of structural things that can be done. Understand that your setting will require different solutions than my setting will. But these are the types of systems that can change. Priming, how many of you know what priming is? Okay, so all that priming means is the thing I saw and thought about most recently has an influence on and can override my biases, right? So for example, I can go into a patient encounter in a hospital that is committed, has changed the culture around implicit bias, and remind me as a practitioner to look at my app on my phone that says, don't forget to account for your IAT, right? And then the Alexander Green study tells us that that simple reminder, priming you most recently, before you go into the encounter, will make you conscious about what you do in that encounter that could be a result of implicit bias. Thank you. So the last category that I want to put into the toolkit is your personal changes. Here again, I want to thank Howard Ross for this acronym PAUSE. P-A-U-S-E. Where do implicit biases flourish? They flourish where there is high discretion, low time flexibility, you're under a lot of time pressure, and high power differentials. So when you know that those are the circumstances, personally pause. Pay attention to the fact that the circumstances are exactly those that are coincident with implicit biases flourishing. Acknowledge the fact that you, as with everyone, are susceptible to reacting, being influenced by, and making judgments that are out of your implicit biases. Understand how implicit bias works, right? Don't make the mistake that was shown on the video in the vice presidential debate. Understand it is distinguishable from racism, that you can intend the best, that your employees, your team members can intend the best, and still have an adverse impact on a patient, on a client, as a result of implicit biases. As search for ways that are constructive to adopt new systems, the app on the phone to prime, a team that is going to collect data and review outcomes regularly so that we're talking regularly about whether our biases appear to be creeping into our decision-making patterns, right? Use constructive or search for constructive solutions. Engage with people who are in other groups. Join a book club. Just having human interaction with people who are different from groups that you are unfamiliar with changes the severity, the impact of implicit bias. Get feedback and data, avoid your first reactions. Have the courage to change the norm around you. So here are some things that I would like to leave with you as a final thought. Implicit biases, unconscious biases, unintentional racism are ubiquitous. They're everywhere. Secondly, they have a far-reaching impact that is perhaps more dangerous with respect to health disparities than even old-fashioned racism was. Why? Because it's invisible. Why? Because the people who are responsible for acting out of implicit biases are people who generally do not see themselves as bad actors. And why? Because we still have not changed the national conversation to understand that unconscious bias is ubiquitous. You don't have to be a bad person. Thirdly, we can all reach beyond our own settings in healthcare to affect implicit bias where it impacts our patients in their social and environmental settings: housing, food distribution, education, and there are other social determinants. We must ask the question, how responsible and what role can we play? There are answers even for health providers. Catholic hospital systems, for example, has partnered with private housing organizations to create affordable housing to remove the biases that affect their patients' housing situations. And lastly, understand that this is a calling. What you are doing with respect to addressing changes in healthcare disparities, this is a calling. It can change not only your patients, your patient population, your organizations for healthcare delivery, but it could literally change the nation. It's that important. So thank you for giving me all this time to talk to you. Thank you for allowing me to push you a little bit beyond your comfort zone. And I appreciate the time that you've given me to share.